Sejam bem-vindos a mais um episódio do Polaris Podcast. Hoje temos o prazer de conversar com Daniel Kaft, médico treinado em Stanford e Harvard com mais de 25 anos de experiência em prática, pesquisa e inovação na saúde, e que atualmente atua como presidente da força-tarefa X-Prize Pandemic Alliance. Não se esqueça de se inscrever no nosso canal no YouTube e de nos seguir nas plataformas de streaming. Eu sou Conrado Abreu e comigo estão André Pastina e Rodrigo Rocha. So, Daniel, to begin with, can you please tell us a little bit about your journey through medicine? Was that something you always dreamed of as a child?
I think as a child, well, first, of course, I wanted to be an astronaut because when I was a little kid, I went to the very last Apollo mission to the moon. I was at the launch of Apollo 17. And even years later, when I was a medical student doing a visiting rotation at Johnson Space Center, I got to meet Gene Cernan, the last man on the moon. But I think I had a sort of a affiliation for science. And I think it was in junior high school that I decided, yes, I'm going to go to medical school, not having any idea what that was. When I got to high school, I ended up doing some research at the National Institutes of Health and sort of got the idea that you could sort of discover something in the lab and translate that to helping people. Actually, my high school science fair project won all sorts of awards and eventually even turned into a drug that Genentech has called Xolair, which is a way of treating allergies like asthma and other elements. And then I went off to college, and while I was in university at Brown, I became an emergency medical technician, an EMT, kind of driving ambulances, and that got me more into the clinical space. And so I think, yes, I had that trajectory from as a little kid through junior high school, and college, and kind of like the blend of science and medicine and clinical. And from there, went off to medical school, and things evolved from there. And I didn't exactly follow the traditional route in that I sort of blended my time at Stanford Medical School doing more sort of immunology research, but I also got involved in space things. I actually went to International Space University when I was a medical student. That's where I met Peter Diamandis, who later co-founded Singularity University. I got involved in other endeavors, and after I did my residency at Harvard in internal medicine pediatrics, I came back to Stanford for fellowships and sort of did the usual in the lab, doing stem cell research, clinical work, but also, branched off into other things. And 12 years ago, joined the founding faculty of Singularity University with a focus on, how does technology enable us to reshape and reimagine healthcare across the planet?
Awesome.
That's great. Yeah. So Daniel, what do you like better, practice or research?
I think I like practical research. I mean, a lot of folks get into very basic research, which is incredibly important. That's how we end up developing breakthrough new technologies like CRISPR, which won the Nobel Prize this year in medicine. But I tend to have the lens of, looking for a problem, a clinical problem that might be, how to address a certain cancer or how to do a better job of getting around fax machines and CD-ROMs to transmit information, and look at how do you not just take research, but connect the dots with solutions that might exist or need to come together to address that problem in new ways. So I think I like applied research and having the lens of things that you can sort of develop and bring to impact, patients and individuals quickly.
So Daniel, before we go to the healthcare industry, I have very interesting. I heard that you, in the beginning, you want to be an astronaut, but I really know that you have some crazy, actions going to in the army, going to the F1 with the airplanes and everything. Can you explain a little bit how you get there and how was the idea to do that, to be a fighter flight pilot?
Yeah, so I always loved airplanes. I grew up in the Washington, D.C. area, so I could go to the Air and Space Museum almost every week. And when I was in college, I got my pilot's license. And I always wanted to be also a fighter pilot, because who doesn't want to be a fighter pilot? But I didn't have 20/20 vision. I didn't have perfect vision, so that wasn't really available back then. But I pursued my passion for medicine, and Actually, when I went to International Space University while I was a first-year medical student, I met another physician who actually was a flight surgeon and had trained in aerospace medicine. And there's a pathway in the United States. It's kind of a branch of the Air Force called the Air National Guard. Every state has its own Air National Guard sort of unit. And in Massachusetts, where I was doing my residency at Mass General, was a F-15 squadron on Cape Cod. And it turns out, they would pay you to be a flight surgeon and fly in fighter jets. I said, I would actually pay you to fly in fighter jets. So I joined the Air National Guard as a flight surgeon, or actually I signed up and then I went to the Brooks School of Aerospace Medicine for about 8 weeks, which included, a lot of, some of aerospace medicine is basically occupational health, but a lot of it relates to aerospace physiology. And we even spent, a week in the wild learning survival skills. So if you're shot down, etc. Anyway, it was a great experience. And then I spent 14 years in the Guard as a flight surgeon, which is basically, the doctor taking care of both the pilots and the squadron and the rest of the wing. And from that, part of your job is to fly with them. So I got a bunch of time flying in the backseat of F-15s and F-16s and other interesting airplanes. And sometimes they let me fly them because they're actually a lot easier to fly than a Cessna. So that was sort of an interesting adventure and gave me a real appreciation for, big organizations, the amazing teamwork and technology that has to go into play in flying high performance jets or doing these sort of international missions. And of course, the medical side of that too. How do you do remote medicine, integrate telehealth, remote diagnostics, all these things that sort of combine aerospace medicine and earth-based medicine.
And is this something you still try to do? Like, do you own a plane, or do you eventually try to fly, or it's something in the past?
Yeah, well, I still have, once you have your pilot's license, you keep it. But actually just this summer, I started flying again properly. And just 2 weeks ago, did my first solo in a new airplane called a Diamond Star DA-40. And the interesting thing about this airplane is it's pretty easy to fly, but it has what's called a glass cockpit, meaning what I trained on was the old-fashioned round dial, sort of the analog cockpit. And now what was interesting is transition to this glass cockpit, which, gives you different symbols and more buttons to push and, moving maps and GPS, a lot more of what we call situational awareness, which actually has a lot of lessons for healthcare. How do we move from our sort of analog era of healthcare, paper forms, charts, reading journals slowly, to sort of this world where we have real-time information at our fingertips that's continually updated, and it gives us an easier way to interpret information and helps us get to where we're going in a safer way, whether that's a surgery or managing a complex patient over months or years. I think there's a lot of lessons to learn, and there's a bit of a challenge to move from our digital to from our sort of analog world to our digital one. So yes, I still fly and love aviation, and I think it has a lot of lessons for medicine, from checklists to flight simulators to the cockpit to even the idea of crew resource management. How you communicate as a team in the cockpit is as important as how a team coordinates in the clinic or the operating room.
Nice. And was that as close as you got to becoming an astronaut?
No, I actually got to the very last stage. I applied and I got the call to come down to Houston to do the final interviews. And so you spend 5 days in Houston, and you go through every medical test and psychiatric evaluation and hand-eye coordination tests. They even had us, practice spacewalking and solving puzzles. And you have an interview with about 10 astronauts. And it turns out my left eye was not quite under the 2200 mark. It had to be 2200. I'm correctable with glasses and contacts, but I couldn't quite get to 2150, I think it was, on that test. So I was sort of medicaled out. So, wow. So the flight surgeon was medicaled out, which is, okay. I've had lots of other adventures since then. And it's fun now to watch. Yesterday, I had my kids watch the SpaceX launch, and if I had joined the astronaut corps, 17 years ago at the time, it would have been a long wait to fly. There's a lot less flying until recently, now that we have a new, very much a digital rocket. If you look at SpaceX, the astronauts don't even have a joystick. They only have touch screens. So it's an example of how we can take really complex technology and sometimes simplify the user interface. But, I'd still love to get to space one day, and it looks like we're opening that up on the commercial side pretty soon.
That's great, Daniel. So now we're talking about complex environment and everything. Let's go to our industry which is very complex as well. So in one of your presentation, you mentioned that the healthcare industry stopped in the third industrial revolution, and we didn't go to the fourth revolution. Can you explain why you think that?
Well, the fourth industrial age is sometimes summarized as this sort of blending of big data and artificial intelligence, and when you log into Netflix, it knows what you might want to watch. When you do your music, it can give you recommendations, and it's streaming at you at 5G or faster. And healthcare is sort of advanced a bit, but is sort of still in that second or third industrial age where things are often disconnected. We're not using data in real time. A lot of things are siloed and disconnected, kind of on different operating systems. And so sometimes it feels like we don't practice exponential medicine, we practice incremental medicine. And for some good reasons, like healthcare can't always advance as quickly as some, new app or widget or device that doesn't have anything bearing on our health. We need to regulate things, when you're developing a new drug or even an app or software as a medical device. But going back to the cockpit analogy, we're sort of almost, with many of our patients and even ourselves, we're sort of flying blind. We're not really flying with a dashboard or instruments. You send your patient home from the clinic or the emergency room or the hospital, and we really have very little insight about what's happening to them day to day. And when we do get data from them, we still kind of fit that into a one-size-fits-all model. What's a normal vitamin D level, or what's a normal cardiac function, when in fact that can be highly variable. So I think part of bringing us into this fourth industrial age is this new era of moving from very intermittent data, which leads to our reactive sick care system, kind of waiting for the problem to come and present in the emergency room or the clinic, to one where we can be much more continuous with our data, whether it's from your Fitbit or from your smart home or your smart bed or your voice, and use that to kind of have the data parsed all the time and go, hey, Daniel, we noticed your resting heart rate when you sleep is normally 56, but it's climbed to 70 over the last week. Maybe something's going on. You need to get checked out. Maybe that when you do need to take a therapy, let's say something as common as high cholesterol, instead of giving everybody the same, 40 milligrams of atorvastatin, Lipitor, it's much more tuned based on their genetics and other data. So I think there's a long way to go where we can start to use now the almost overwhelming amounts of data and turn that into information and have almost that equivalent of the high performance dashboard we have in a plane today to kind of guide the course of a patient's journey from birth to their childhood and raising in a healthy way, and then screening and other interventions that are really matched to them. Like, you don't manage the mechanics of a 1968 VW Bug as you do for a 2020 Tesla. Both have wheels, both drive, but need very different sorts of maintenance. And, the Tesla is basically a computer on wheels. So I think we can start to bring all these technologies together to really bring us to that fourth industrial age.
Yeah, and that's perfect, Daniel. And so as a consequence of this question is, do you think to double the pace to reach this, you think we need more engagement from the doctor or the patient, or from both? Because that our industry in some way, people are a little bit scared to advance in terms of technology. They think that this is just a hippie thing, or a hippie thing, or a trendy thing. So what do you think we should do as a next step?
I think we need to always be careful and sometimes take our time in advancing things in healthcare, but it's also a danger if we sort of hold on to the past. And sometimes that's because, that's how the head of the department wants it. They don't want to, change to the, better cardiac sensing device because, that means they can't charge the same amount for it, or they won't have the same power structure in the hospital, for example. We need to understand not just evidence-based medicine, but how we really practice incentive-based medicine. And so we do need to engage, especially the clinicians, to use these sorts of emerging tools, because in many cases they can dramatically improve, prevention, diagnostics, therapy, clinical trials. But it has to sort of be something that works into their daily practice, and essentially, in the end, that the clinician, the hospital system can get paid for. So there's sort of often a challenge in shifting between analog and digital, right? There's a lot of sometimes transition costs when you move from paper records to electronic. And many of these times when you move to, let's say, electronic records, that isn't true digital health. We're stuck now. Often physicians, nurses, and others are getting burnt out because they have to spend all this time as data clerks, entering data mostly for billing, not for for patient care. So you need to be careful about when you integrate new technologies, having it work and match the workflow of the clinician, doctor, physician, doctor, pharmacist, nutritionist, whoever it might be, so that we can integrate those in smart ways. And then, of course, tie it back to the patient and use these in ways that they're going to engage with. Because if you give them 10 apps and 10 wearables, that's overwhelming as well. So I'll stop there for a second to say I think it takes the entire endeavor, and that means understanding where the incentives are. That's why, healthcare systems and payers are part of the solution as well.
So Daniel, perfect. We've been seeing a lot of innovations in medicine, especially involving technology, gadgets, and devices, as we said. When you look at the COVID situation, do you believe that at this point we should have been better prepared for events like that?
Well, the pandemic, it's a global event now, right? It started as an epidemic, locally. And I think we've had technologies and have some that can start to pick these things up sooner, sometimes not just by, viral PCR tests, but from digital biomarkers or, screening the news, and maybe are in the future able to identify and lock down travel from a particular area, let's say, in a faster way. I think a lot of our potential, I think both in the US and Brazil, could have done much better using our existing technologies, including, testing technologies. Such a key part of managing an infection in epidemiology is test, trace, and isolate. And we were very behind, especially in the United States, on testing. I'm involved with the X Prize. We launched this summer a $5 million prize for frequent, fast, cheap, and easy testing. So imagine all of us, using our phones or the equivalent of something as easy as a pregnancy test, could do COVID testing at home or at school or at work to help us, safely re-enter and identify folks, particularly when they're asymptomatic. So I think we've had a failure on testing. We are seeing, of course, advancements moving very quickly in vaccine development. And today we're speaking on, in mid-November, and we just had the announcement from Moderna that their new vaccine looks to be 95% effective, meaning of the 30,000 patients in the trial, 90 who got the placebo got infected, and 5 who got the vaccine became infected. So it's looking promising. So there's pluses and minuses. I think we can and we need to do a better job in the future using, common public health measures and pretty available technology.
Great. And speaking of which, Daniel, can you share with us and our audience what the X Prize Pandemic Alliance is all about?
Well, early in the pandemic, obviously, a lot of concern even about having enough ventilators or personal protective equipment, which, by the way, are still a concern several months later. And, we're seeing a lot of innovation happen, like all these groups, 3D trying to 3D print ventilators with some pretty amazing solutions. But we don't need 1,000 versions of 3D printed ventilators or new masks. We need a few that work and can scale. So part of the idea about the X Prize Pandemic Alliance is we brought together over 100 different organizations, from NGOs, big companies like IBM and Intel, to small startups in digital health and beyond, to academics like UCLA and MIT, to the Veterans Administration, to go, how do we collaborate together to, find the challenge areas that might be in triage and testing and vaccine development and transmitting information, and find some of the best solutions to help bring those to market, or basically cross-fertilize and better collaborate. So that's a lot of what we've done. And part of the things that have come out of that have been some actual challenges, like a improved mask challenge, which is for college students. And they're in the finalists now, some pretty amazing innovations on making better masks. There's a challenge around mental health and COVID. And then this rapid COVID testing X Prize I mentioned. But a lot of it, again, is that one of the silver linings of COVID is that we can better collaborate around the planet. The knowledge that we might learn in an intensive care unit in Italy, transmitted to New York, transmitted to Sao Paulo. And so we're kind of creating more of a hive mind, where my hope is that a lot of the amazing, collaborations and catalyzation of, virtual care and remote patient monitoring will end up, post-COVID, saving more lives than COVID took globally, even though it's been horrible and over 1 million lives have been lost. So part of what we're trying to do for the Alliance is address those challenges in a collaborative way.
That's great. And Daniel, by the way, are you seeing good results, or probably you're seeing a lot of people engage on this, trying to solve this problem, right? Because we have been seeing more and more, especially during pandemic or World War, where the innovation goes through and people really focus on innovation. So probably you guys are seeing a lot of progress on this.
Well, there's a ton of innovation just on the testing side. For the Rapid COVID Testing X Prize, we had over 707 teams apply from 70 countries with all sorts of ways to do it. Some of them are based on more common PCR tests, some based on LAMP and antigen testing, some even using voice and breath. So, a ton of innovation coming together. And of course, it's not always about the actual tech stack, right? You might have a very good molecular test that's very accurate and very sensitive, but it needs to be affordable, it needs to be able to scale. One of the initiatives that helped come out of our Alliance was this idea of a digital yellow card. Once you've been tested negative, or hopefully eventually have the vaccine, how do you prove that? How do you prove that that Daniel or Rodrigo really had the vaccine or was tested negative that morning to enable you to go fly on an airplane or walk into a Starbucks? So there's a platform called Common Pass, which is now launched. It's working with airlines and others, and will be a bit of that digital yellow card on top of this. But yes, a ton of innovation. And sometimes it's, again, not about always the technology, but how do we build these solutions so they're being used? Like a contact tracing app is great, but it's only useful if a lot of people are using it.
That's good. And Daniel, by the way, I have another question based on this. So how do you see the balance between the new race for new technologies and products? I mean, in a business perspective, versus the sustainability of the healthcare
Well, I think,
industry.
we don't need to wait for the future. There's a lot of technology obviously already here in 2020. Some of it's really incredible. What you can do with even a smartwatch now for picking up COVID or the flu or atrial fibrillation is pretty incredible. The trick is, how do you integrate that into your healthcare system, whether that's a virtual visit, a clinic visit, an emergency room, a hospital room, an intensive care unit. It's sort of often a challenge, for the leadership of big health systems. Like, how do you pay for these things, wire them in, particularly when they change pretty often, right? You want to future-proof things. You don't want to build for 4G and then find out, whoops, 5G is here and then 6G is here. How do you end up building a system that can evolve and adapt with a little bit of that, exponential perspective that, today, sequencing an individual patient might cost, $200, $300 US, but in 4 or 5 years, that will be $50 US, cheaper than a chest x-ray. Or how do we appreciate how quickly artificial intelligence and big data is moving to help, augment a radiologist or other diagnostics, or voice as a platform that can be used in the clinic, in the OR, or at home. So, we all are excited about the future, but I think what we have today is pretty incredible. The challenge is how do we make it equitably distributed? I think, there's lots of gaps in care, from the rural Amazon to rural Africa to rural California. And, we can use some of these existing technologies. A smart app, as example, in China, there's an app called Good Doctor, which now has like 300 million users and is dramatically changing the game for millions of Chinese who had almost no access to healthcare in the past. So lots of potential.
And Daniel, that's a great point. And what we have been seeing as well is there is a lot of players from other industry, for example, Google or Amazon or other ones trying to enter in the healthcare industry. So
well, I think it's exciting because the Amazons, the Googles, the Samsungs, the Facebooks even, they're what we're all interacting with all the time, these sort of consumer platforms. Even Twitter, I think, had a healthcare component at some point. They may still, meaning they can do certain things very well. What does Amazon do really well? Supply chain and consumer engagement. And what does healthcare not do very well? Sometimes it's consumer engagement and that kind of interaction layer. And so I think what's interesting about Amazon, particularly in the United States, is they can cut out the middleman, right? In many cases, so much of healthcare, I think you know this, is sometimes 30% of the costs are because we're faxing things and repeating orders and waiting for billing codes and verifications that you can do this test or another, and we can get rid of some of that friction through our digital layers. And Amazon, I imagine in a couple of years in the U.S. we'll have the option to get Amazon Health Prime, and you have a membership, and when you need your drugs, PillPack will deliver it by drone, or it'll show up the same day, using the sort of backbone of that. Or Apple, right? They don't want to become the healthcare provider, but they want to provide sort of the platform element, where the data, they don't want to own the data either, but they want to provide the conduit, right, through your smartwatch or smartphone or smart home. And so in a sense, you can all be collaborative with all the big players. And in some cases, they may try and go off on their own and do things that we can learn from in a cross-fertilized way.
Daniel, do you think it's somehow easier for companies that are not in the healthcare industry to promote this disruptive innovations? Because maybe the healthcare companies, they are so big, or they have so much responsibility in today's patterns, that it's not that easy to create something new, and maybe these other companies will have room for this kind of improvements.
Yeah, I think in general, a lot of the innovation coming from healthcare comes from outside traditional healthcare, because many of these folks, including the entrepreneurs themselves, have beginner's mind. They may have been a VP at Apple and got really good at building, search engines or other technologies, and then they see a problem in their own life, and they apply their ability to connect the dots and use some of these new data and other layers to do that. For example, I'm working with Jeff Huber, who was formerly a very high-level VP at Google. His wife unfortunately died from colon cancer, and then he, from that experience, founded Grail, which is a company using blood-based sequencing to find cancers early when you can make a difference, pretty much non-invasively. So that's an example of someone coming from outside of the industry making a huge impact. That company's just been bought by Illumina for, I think, $8 billion. You've got lots of examples of companies that might have been doing, other video games. Video games are coming into healthcare for training medical students or keeping patients engaged. You've got all the folks doing AI and big data, augmented reality, virtual reality, that are all have tremendous opportunity around, say, medical education. So I think, for folks who are outside of healthcare, it's an amazing time to contribute in some form. For folks who are sort of in the main setting of a large healthcare organization, to think about how do you build a bit of a innovation team inside of your company that is nimble and isn't crushed by your organization, quarter to quarter. And how do you, sometimes you need to acquire these innovations. But I think it's a great opportunity to sort of rewire how we do innovation, and for both small startups and very established companies to start to do things a bit differently, with this idea that, again, it's this convergence of pretty much pretty new technologies: AI, robotics, 3D printing, nanochecks, synthetic biology, VR, AR, blockchain, that when you synthesize them in new ways, you can really address big problems.
Daniel, how invasive are the healthcare wearables in the legal or privacy perspective? And how US are treating the collected data?
Yeah, great question. Privacy and data and who owns the data is always a hot topic and an unsolved challenge, because it's different across different regions, right? If you're in Europe and you have GDPR, or some places in Asia, there's very little privacy rules, etc. I think we need a bit of a balance. A wearable, a simple wearable like a Fitbit or a smartwatch, can tell a huge amount of information about you. You can even tell who's wearing it, because each of us have a bit of a fingerprint on our gait. So, you can't just put your Fitbit on your friend and have them go run a marathon and take credit for it, in the future. And some healthcare payers, as you know, are actually, giving incentives for folks to hit a number of metrics. But so I think, we need to be careful about making sure data is anonymized, but is shareable when people want to share it, that patients or humans can be rewarded for sharing some of their digital exhaust and other information in some ways. I always like to use the the analogy of Google Maps or Waze. From when we drive, we share data about our speed and location. That's pretty private information, but from that we build a crowdsourced map of the traffic, and you know what highway is fastest and when you're going to get there, and you can help report an accident or a police trap. And so I think if we all can start to see that if we're collaborative and we share our data in some form, that builds a better healthcare map and journey for all of us. That's important. And then in the United States, we often have challenges with old regulations. One's called HIPAA, Health Information Portability and Privacy Act, which was, I think, a law that was written before the digital age and now hasn't really adapted very well. So now there's all sorts of challenges for startups about potentially being able to share clinically relevant information, and a lot of fear around that and misunderstanding. So we need to update our regulations as we go forward as well, so that we can speed up, virtual clinical trials and, save lives. I've had situations as a physician where we're waiting to get the medical record faxed over from the other hospital because they wanted the signature of the patient, and the patient may have died by the time the record gets there. So the patient died with their privacy intact. I think that patient rather survived with a record that was received more quickly, even if there was some risk of data being shared more quickly.
So, Daniel, one question that I have is, I know that you are passionate. I am passionate about technology as well, the gadgets and how and where we are going in terms of healthcare and the medicine. But are you afraid in terms of we are getting so, high technology and so low in high touch? When you go for a long time ago, the eye contact, and the compassion was very strong. So because in some way you see them, you touch them, and now it's more like our technology, especially now during the pandemic. So
I think number one, I think there's a danger of just calling all these things gadgets or little toys, and some of them start that way. Even the consumer wearables were helpful to track your steps and then your sleep, and now can be used in all sorts of ways, even for managing chronic disease or post-surgical care. And yes, we don't want to become over technology. We want the technology to sort of disappear into the background and actually help re-enable the human touch piece. Because what happens now when you go into your primary care doctor or specialist, they might have their back to you and they're just asking questions and typing, records into the horrible epic fail, I like to call it, medical record system, which is a record system. It isn't a health system. It doesn't really provide much guidance to the clinician to say, hey, you've got Andre here, and you're about to give him a statin that is the wrong one based on his pharmacogenomics or his kidney function. I think we need to start better seeing how we connect the dots and don't make it these all about wearing multiple wearables or having multiple apps, but how do you kind of create a single synthesized piece? And back to the human touch, if you're my patient, you come into the clinic and I can, look at a sort of easy to understand dashboard of how you've been doing, how you've been sleeping, what are your vitals been doing, what has your blood pressure been doing if you're being treated for high blood pressure. I don't need to spend, 15 of my 20-minute visit asking you questions of things you can't even remember, but I can spend that time face to face, eye to eye, going over your problems in context and hopefully providing solutions and helping you use the ones, whether they're digital or a drug or a device or a social platform, that you can address them better. So I think in some ways technology will help bring back the human side, because soon we can use, already starting to happen with machine learning, they can listen to the clinical exam and write your note for you, right? And give more time back to the clinician to do the human part of healthcare.
That's perfect. And Daniel, so I had opportunity to meet you in the Singularity University, and one of the topics there was around the singularity, when man and machine will become one, and with that we can live almost forever. So if this happened, how do you think is going to be the role of a hospital, for example, in this circumstances? Because
part of it, quote unquote, singularity is when computers get so good that they're far better than the human brain, and your mobile computer, your smartphone, which is already pretty incredible, is you have more capacity than you or 1,000 others. And I'm not a pure singularitarian. I mean, Ray Kurzweil is amazing. I think it's important to appreciate the power of exponential and fast-moving technologies, but I'm not one of those folks who's like a transhumanist and thinks we should turn ourselves into robots. Though in a sense, we already are transhuman, right? Many of us have, whether it's a hearing aid or, you can argue that our mobile devices are an augmentation of our brain already. And so I think, we'll hopefully continue to have our human parts, but, just because you have an artificial heart or you have a 3D printed, regenerated, liver made from your stem cells to improve not just your lifespan, but your health span, those can all be very good things. And, healthcare will evolve with it. I mean, here in 2020, there's now been demos, by Elon Musk, who beyond SpaceX is doing a brain-computer interface company. They've demonstrated on pigs right now, and other companies have demonstrated almost with humans that, we can interface these technologies with our brains, for example, and it's going to get more and more incredible over the next decade. And I think, healthcare will certainly adapt. We need to be careful about disparities. I mean, it's amazing to have, CRISPR gene therapy to cure a genetic disorder, but there's so much we can do for the 80% of the world population who has almost no access to healthcare, whether that's just via a simple smart tablet and information, or eventually digital apps and digital therapies, or local 3D printed medications, things that can provide that base level, and also recognize that it's our social determinants, clean water, vaccination, social connection that are actually even more important to our long-term health and happiness, not the sort of fancy AI robot surgeon.
And Daniel, what happened with this is more a curiosity, okay? What happened with
IBM Watson, they're early in this sort of AI meets medicine stage. Arguably, they spent more time on marketing and hype than developing their product, et cetera. I think some very good things have still come out of IBM Watson. I just don't think it quite met all the things they anticipated as quickly. But it doesn't mean, with one or two more clicks of Moore's Law, what IBM Watson was able to do in beating the champions of Jeopardy, that used to take a whole room of computing. Now you can access that, in real time on your smartphone. Watson, I think, is powering a lot of things from weather to other medical things. So I can't give you the full update, but they were maybe a little, they often didn't, as far as I understand it, have enough real doctors on their team either who could really translate, the potential into the actual clinical environment. Because like with many technologies, if you don't understand the patient perspective, the payer perspective, the pharma perspective, and in the location, things may not be adapted. Also, they learned some lessons like, trying to do cancer guidance. They trained their cancer AI only at, one hospital in New York City. So a lot of the recommendations, were kind of out of the heads of that set of physicians. And I think what we're going to see is AI and other systems need to make sure the data comes from broad sources. Like if you're just doing all your genetic databases off of, European Caucasians and not African Americans or Asians or South Indians, you can end up with a biased data set as well, and your AI won't function as well for the right person at the right time.
Daniel,
that's perfect.
We have a game here called Icebreaker, which is a deck of cards with random questions. We used to pick one and read to our guest. Let's play.
Okay.
Just a minute. Okay. Do you have any hidden talents? What can you do?
My hidden talents?
Yeah. Do you have any?
I don't know if they're hidden. Let's see. I can still ride a unicycle. I taught myself to ride a unicycle when I was maybe 15, and I could still ride it. It's actually the same unicycle, and I took it out for our socially distanced 4th of July parade this year, and it's just like riding a unicycle. Once you have it wired into your physiology, you can still do it. So that's, I guess, a hidden talent. I play a bunch of instruments, piano, saxophone, clarinet. I haven't played much lately, but I think you find a lot of people in healthcare are pretty musical. That's kind of an interesting phenomenon. And you could argue that things like jazz and music and collaboration, that happen in healthcare might be helped by having some experience in playing in bands and orchestras. Other hidden talents. That's all that's, rated PG.
All right. And Daniel, one of the other traditions of our podcast is a request for a film or a movie and book recommendation that positively impacts you. Can you share with us what your choices would be?
Wow. Well, a good short book I read years ago, and I reread it once, is Jonathan Livingston Seagull, and that always reminds me that we're social, we're like a flock of birds, and we tend to like to flock together. But the story of Jonathan Livingston Seagull by Richard Bach tells the story of this one seagull who decides to learn how to fly higher and do acrobatics and, all the challenges he has being different, but how he sort of helps get him and eventually his flock to a higher place. And maybe that's kind of what we need to do in healthcare. Sometimes we need to sort of get out of our usual flock. So that would be one good book. It's a short read, Jonathan Livingston Seagull. And then a good movie. Wow, that's a tough one. Boy, I just rewatched Hamilton, the musical. It's always, great music, and it gives you, appreciation for history, and that all these historical figures were actually real human beings with positives and negatives. Let me think of a better. There is a movie.
It can be a guilty pleasure. We won't judge you if you like Caddyshack, for instance.
Caddyshack or Groundhog Day were brilliant older movies. There's one I think it's with Richard Hurt called The Patient, and it's for those of you who are in healthcare, it's a really powerful movie. I'm just going to look it up. I think it's The Patient with Richard Hurt, I think, and it's the story of a ear, nose, and throat patient who ends up a physician who's this very egotistical surgeon, and then he gets cancer. And it's a pretty powerful movie. I think I've got the name of the movie wrong. But that's sort of a powerful movie I always remember as well. Perspective, right? What the magic of movies is they can give you perspective and lessons, in a short period of time.
That's great. Daniel, so we reach our end here of our interview. One more time, was really a pleasure. And I'm sure that a lot of people will learn a lot. You inspire a lot of people, and I think this was a great conversation, not just for us here, but I think for our audience. So one more time, thank you for joining us.
Thanks so much. Great to be with you, all of you, and thanks to all the work you're doing. The movie I just got, probably wasn't the Patient. It's called The Doctor from 1991. Very close, with William Hurt, and it's a good sort of lesson in being humble and having the patient perspective, even when you're sometimes in control of a medical system. But yeah, thanks for having me. A fun conversation, and happy to help out with future adventures.
Thank you.
Thank you so much, Daniel.
Obrigado.